So good afternoon, good evening, wherever you happen to be in the world today. One sec. My name is Neil. I'm a consultant in palliative medicine, working in Abu Dhabi, and welcome to this evening session of the Advanced Painful Neuropathy webinar. This is a webinar which is focusing mainly on specialist level neuropathy, so advanced neuropathy. This is a webinar which is been put together in collaboration with the International Diabetes Federation of the MENA region, and is endorsed by the Emirates Oncology Society and the Saudi Pain Society. And least but not last, we must say a thank you to Medtronic for supporting and sponsoring the program. So this evening we have a program of 4 presentations covering the full, I suppose, the full wide-ranging spectrum of advanced neuropathy. I can speak as a palliative medicine doctor that a significant proportion of my time is involved in treating patients with very difficult pain. And maybe 70% of the pain that I'm involved in treating is quite recalcitrant, persistent neuropathic pain, and it's a real problem. Increasingly, I work a lot with my colleagues in anesthesia and interventional pain. And I think over the past number of years, certainly from palliative care's perspective, we have a much closer working relationship with our pain colleagues, and we refer patients for intervention at a much earlier stage now than we did, say, 15, 20 years ago. And I think also with cancer treatments changing, particularly, we're seeing younger patients or patients having cancer treatments for a longer time. And so a lot of these patients, I think, should be referred for interventional pain intervention at a much earlier stage. So today we are going to focus on the full range of neuropathic pain. We're going to talk a little bit about pain in general, what neuropathic pain is, the clinical dilemmas in managing and treating neuropathic pain. We're going to then focus on the role of the pain clinic and how that fits into pain services. And then we're going to finish with a presentation on spinal cord stimulation by Professor Boucher. So we are very fortunate to have a very, very esteemed group of faculty. And these are clinicians who do both clinical work and research. And so I think this evening should be quite exciting. And certainly for me, it'll be a very, very good reintroduction and revision of neuropathic pain. So without any further ado, I'm going to start with the presenting the first presenter. Just a little bit of housekeeping. What we're going to do is we're going to run through all the presentations and we're going to leave questions till the end. I'll talk to you a little bit about the CME housekeeping at the end as well, if that's okay. So our first presenter is Professor Abdullah Kaki, who is from Saudi Arabia. And I think most people in the audience may well be aware of who Professor Kaki is, as I think the Saudi contingent makes up the biggest number. So Professor Kaki is a consultant in anesthesiology and pain medicine and is the director of the pain clinic at King Abdulaziz University in Jeddah in Saudi Arabia. And he is, I can't find any adjectives to say, he's extremely well qualified and well known and is active both in clinical work and research. So I'll hand things over to Professor Kaki.
Thank you, Mr. Chairman. Assalamu alaikum. It's a pleasure to be part of this webinar and to talk about prevalence of neuropathic pain. I'm the first pilot in this journey, so bear with me and fasten your seatbelt because I'm going to do the takeoff. So if you face any turbulence, blame the main pilot, Dr. Eric Boxer. Anyway, as a pain doctor, I have nothing to disclose. And the agenda for my lecture is here. I will talk about the pain definition and then I concentrate on neuropathic pain. I'll touch on the causes of neuropathic pain, the prevalence of neuropathic in general. Then I'll talk in particular about diabetic peripheral neuropathy and about the problem in the MENA region. Okay, so last July, actually the 17th of July 2020, the International Association for Study of Pain made few changes in the definition of pain. We all know that pain is unpleasant sensory and emotional experience associated with actual or potential tissue damage, or whatever the patient used to describe that damage or pain. They added 6 keynotes actually to the definition to make the understanding of pain better. So pain is always a personal experience that influenced variable degree of biological, psychological, and social part of the patient. And there's a huge difference between pain and nociception. One is the process of pain and one is the end result. And the life experience of the patient will make him more accustomed to pain and learned about pain more. Personal report of experience his experience of pain should be respected. Unfortunately, some doctors, they don't do that. And the 5th keynote is that pain usually serves as an adaptive role and may have a adverse effect, and we should concentrate on that because it affects the function, the social, and the psychological well-being of the patient. Finally, those patients that cannot communicate or express their problem, we should respect them and provide them with the best pain treatment. Okay, so if we concentrate on neuropathic pain, then it's a lesion or a disease involved the somatosensory nervous system. And the group led by the Dairy actually in France were the first to describe this problem, and that's the neuropathic. It's not mainly a nerve, it's a somatosensory, not a sensory nerve, but somatosensory nervous system, and we have to consider that in the treatment of neuropathic pain. Now, the causes of neuropathic pain, it's a wide group of causes, and we have to consider that. This could be a metabolic disorder, like the one we are going to concentrate on, the peripheral diabetic neuropathy, or any nutritional deficiency like vitamin B. And it might be as a result of infection with a post-operative neuralgia, the result of peripheral neuropathy associated with AIDS or leprosy. It might be an autoimmune disease, multiple sclerosis, Guillain-Barré syndrome, and it might be a toxic effect of drugs, whether chemotherapy or antibiotics or others. Trauma can be blamed for neuropathic pain with a spinal cord injury, brain injury, or post-amputation, and it might be related to inflammatory disorder or hereditary neuropathic disorder. So we have to keep all that in our mind when we look after patients with neuropathic pain. Now, the main bulk of my lecture is about the prevalence of neuropathic pain. Now, if we talk about chronic pain in general, we know that it's so difficult to assess the incidence of the prevalence of pain because there's different way to estimate that, different way to define pain in different parts of the world, and different tools and methods to assess the pain. So we cannot get a rough end result, but in a systematic review actually conducted in 2014 and published in Pain, they considered that the prevalence of chronic pain was ranging from 3 to 17%, and the incidence of post-herpetic neuralgia is 4 to 42 per 100,000, while trigeminal neuralgia was 12 to 28 per 100,000, and diabetic peripheral neuropathy was the most commonly occurring one, from 15 to 72 per 100 person. So, according to this, a crude estimation of neuropathic pain prevalence will be 1 to 3 in the global population. Now, most of the study revealed that neuropathic pain is more common among female. It's around 60.5%. The age between 50 to 65 is affected more with neuropathic pain. It's common among manual workers, and that might be related to trauma, and among rural area and illiterate people. Now, if we decided to go to the diabetic peripheral neuropathy, the main topic of our webinar, we found that the International Diabetic Federation estimates that the prevalence of diabetes in the whole world in the year 2017 was 425 million. And they expect this number to increase to 628 million by the year 2045. So we're facing a problem that is growing actually, and it's not decreasing, it's increasing. Now, diabetic peripheral neuropathy is the most common cause of neuropathy worldwide. And 50% of the diabetic, most of the study complain of diabetic peripheral neuropathy. Unfortunately, this leads to higher incidence of morbidity and mortality and to impair the patient's life in all aspects. Now, if we just take one country like the United States of America, they start their voting, so let's talk about them. 1/4 of the US healthcare expenditure on diabetes is spent on peripheral diabetic neuropathy. So that's a huge amount of money just to solve this problem. Now, in epidemiological study, if you want to conduct many to assess the diabetic peripheral neuropathy prevalence, we'll find that's not easy job because it's lead to heterogeneous results. We are involving different population and different group sample. The definition of neuropathic pain and the definition of the symptom and sign differ from one study to another. The method to assess the pain also differ from one study to another. Now, if we started with UK, a study was done 17 years ago, 1993. They did a multi-center study and they involved 6,500 UK diabetic patients. They found that diabetic peripheral neuropathy, it's appear in 28.5% of those patients. But this study was mainly dependent on a questionnaire and answer to that questionnaire and examination with the patient if it's positive. Another study conducted in UK, this was done in 2011, and they involved higher sample size of 15,000. They found that the incidence is higher. It's 34% actually. It's more common among type 2 diabetes, more common among women, and those people coming from South Asia and living in England. Now, if we leave the United Kingdom and go to United States of America and particularly to Colorado, we find that the San Luis Valley cohort study conducted there, and they found that the incidence and the prevalence of diabetic peripheral neuropathy is 25.8 among diabetic patients, diagnosed one, and it's 11.2 in impaired glucose tolerance patient. It was 3.9% in the control. So not only diabetic patients develop diabetic peripheral neuropathy, even those with borderline diabetes or impaired glucose tolerance have peripheral neuropathy. And of course, the control have other causes for peripheral neuropathy. In Germany, they conduct another study with a good sample size, and they found that the prevalence is 13.3 among diabetic, while it's 7.8 in impaired fasting glucose patient and 4.2 among the control. The PROMISE study, they tried to follow up the patient longitudinally for 3 years to find out whether there's problem of complication. And they used the Michigan Neuropathy Screening Instrument to assess that. And they found that the peripheral diabetic neuropathy is as high as 50% in diabetic, and it's 49% in pre-diabetic, and it was 29% in the control. So it's a major problem for diabetic patients. Actually, it's one of the complications of diabetes with diabetic peripheral neuropathy. The Schuster neuropathy study conducted diagnosis of neuropathy, and they use more than one way to assess the neuropathy. They use the neuropathy disability score for the nerve conduction study, or the neuropathy symptom score, and they conducted the study among 380 patients. They found that 66 of the type 1 diabetes and 59 of type 2 diabetes, they have diabetic peripheral neuropathy. In NeuroDive study, they tried to assess the complication among 3,000 patients across 16 countries in Europe. They found that the prevalence of diabetic peripheral neuropathy is 28%, and it rise to 53% after 7 years. So from 28, following up the patient for 7 years, it becomes 53%. And they considered the following factor as a risk factor for that: the older age, the longer duration of diabetic, poor glycemic control, high hyperlipidemia, obesity, hypertension, and smoking. Now let's concentrate on our area. The MENA, the Middle East and North Africa region, is this in the map here. It's the Middle East, adding to that Turkey, Iran, and of course Israel. Now, if we look at the study, and that was a little bit difficult for me to get the number of study because most of them they are published in local and national journal, but we managed to find good number published in the last 10 years. So if we started with the Gulf Diabetic Care Survey, which involved 1,290 patients referred to the diabetic clinic and the general hospital in Saudi Arabia, Kuwait, and United Arab Emirates, the prevalence of diabetic peripheral neuropathy was 34.9. This survey was depending mainly on a questionnaire, including yes or no. You have the symptom? Yes. You don't? No. So it's not that accurate, but it gives us a rough idea. From Bahrain, Mahrouz and his group actually included 1,400 patients referred to the primary care diabetic clinic, and the 93 of them, they were type 2 diabetes, and they found that the diabetic peripheral neuropathy assessed by two assessment tools, either the neuropathy disability score or the neuropathy symptom score or the vibration perception threshold, one of these two out of three, they found that the prevalence here is 36.6. And associated with peripheral vascular disease and foot ulcer as well, in 11.8 and 5.9 respectively. Now, in Emirates, a random sample was collected in Al Ain area from original Emirati people, and they included 2,455 adults. They found that the prevalence of diabetic peripheral neuropathy actually is 34.7 among those diagnosed with diabetes, and 16.2 among non-diagnosed diabetic patients. It was 11.5 in the pre-diabetic. So the number is high, actually, for the number of the population, whether we are talking about Bahrain or we're talking about Emirates. The Saudi National Diabetes Registry, actually, including 62,000 patients, they assess 11,000 patients of those for diabetic peripheral neuropathy, and they found that 2,057, which is 18.4%, they have diabetic peripheral neuropathy. And of course, the prevalence of ulceration, amputation, and gangrene was higher among those patients. Another large survey came from Iraq, actually, involving 4,009, almost 5,000 diabetic patients. And they followed them for 6 years, from 2003 to 2009. We found that the prevalence of advanced diabetic peripheral neuropathy is 13.8, but they depend mainly on the symptom. The patient has numbness, paresthesia, and sign of absent vibration or knee or ankle reflex. In most of those patients, their hemoglobin A1C was 9.3 plus or minus 2. Even in Palestine, a recent study published by the UNRWA, under the United Nations, they included 2,000 refugees, and they found that the diabetic peripheral neuropathy is among 52.6 of them. And most of them, they have hypertension in addition to diabetes. Now, in Egypt, unfortunately, in the last 10 years, it's only 2 studies came from Egypt. One cross-sectional study conducted in Alexandria, Egypt, and they included 500 type 2, 300 of them diagnosed with diabetes, and 183 newly diagnosed. And they tried to assess for diabetic complication. They found that diabetic peripheral neuropathy in that sample was 20%, 29 among the non-diabetic patient, and 3.3 in the newly diagnosed patient. Another study came from MENA. It includes 9,000 patients, and they found that 837 of them were diabetic, and the majority of them are type 2, and diabetic peripheral neuropathy is 18.5. But in Egypt, it was common among female, among those living in rural area and illiterate population. We left the Middle East and we go to North Africa. We find that in Tunisia, they included 2,300 diabetic patients. They found that prevalent diabetic peripheral neuropathy is 18.7. But again, in this study, they didn't define what is diabetic peripheral neuropathy. In a similar way, another study came from Morocco involving 1,196 patients that revealed a higher prevalence of diabetic peripheral neuropathy of 45.6. The only study I found coming from Yemen, actually including 1,000 patients, and they followed them for 5 years, and that revealed a diabetic peripheral neuropathy prevalence of 40.7. But all this study, they didn't mention how they diagnosed diabetic peripheral neuropathy or what was the central oversight. In Turkey, they conducted a multi-center study and they involved a good sample of patients, 1,113, both type 1 and 2, to find out what is the prevalence of diabetic peripheral neuropathy, and they found it 62.2. And this is depending on bedside testing at 40.4, the other without bedside testing. They found that poor glycemic control, hyperlipidemia, microalbuminuria, and foot amputation associated with higher prevalence of diabetic neuropathy. Now, this is a graph that I like you to see. This will show you the diabetic peripheral neuropathy. So the highest, this depends on the population of the country, was Palestine, followed by Iran, then Saudi Arabia, Morocco, and so on. The lowest was in Oman, actually. But it's all ranging in the higher range. So if you look, they're all 30 to 52. If we look to the painful diabetic peripheral neuropathy, we found that we in Saudi Arabia came in the first position, and then followed by Egypt, Jordan, Lebanon, Kuwait, Morocco, then the whole Gulf countries, and Turkey. And this was published in 16, sorry. Now, the International Diabetic Federation, they think that's a true prevalence of diabetic in the MENA region is 12.5%. Unfortunately, this will raise to 14.3 in the year 2030, and it will become #1 in the world. So the highest in the world. 6 out of 10 countries in the world suffering from diabetes, with the high prevalence of diabetes is in the Middle East. Qatar, Kuwait, Lebanon, Bahrain, and Saudi Arabia. So it's a major problem, and this webinar is one of the first things that we have to do to improve the knowledge of all practicing doctors and improve the care of our diabetic patients. So in conclusion, diabetes and diabetic peripheral neuropathy is a major problem here for us in the MENA region. Majority of the study, unfortunately, doesn't define the prevalence of diabetic peripheral neuropathy as the painful one. They rely on questionnaire and subjective way to assess the patient. No study has evaluated the small fiber neuropathy. They mainly talk about large fiber, and we need more research, more objective method to assess the diabetic peripheral neuropathy, and unified all our effort and resource to reach a better treatment and a better life for those patients. Thank you, Mr. Chairman.
Excellent. Thank you, Professor Kaki, for that very comprehensive overview of the prevalence of diabetic neuropathy. And it is sobering to see that those numbers are predicted to increase so dramatically. We can use that as a nice stepping board to move on to the next talk by Professor Mohammed Hassanain, and he's going to talk to us about the sort of the dilemma of managing peripheral neuropathy from the perspective of diabetes. Professor Hassanain is a consultant, a senior consultant, in endocrinology and diabetes at Dubai Hospital in the UAE. And prior to that, he spent many years as lead consultant in endocrinology and diabetes in Wales in the UK. More commonly, Professor Hassanain is also Deputy Director of Postgraduate Diabetes Education in Cardiff University and is the chair of the Diabetes and Ramadan International Alliance. So I'll hand over to Professor Hassanain now.
Thank you very much, Neil, for the kind introduction, and thanks for Medtronic for organizing this very important topic. I'm delighted that Professor Kaki has covered many of the important points and reflected on the really importance of this area of health and medicine is largely neglected. Certainly from diabetes point of view, it's not very well addressed, and perhaps that's why the dilemma of the exact figures. I'm going to talk about another dilemma of the patient with painful neuropathy, of how can they best get the best outcome out of their problem. Quality of life is a very important aspect. And you see here from this information that in people with diabetes, one of the major problems of quality of life is related to neuropathic pain and the presence of neuropathy. So the reduction of quality of life is very much related in diabetes, as per the NICE report 10 years ago, on the presence of either ulcers or indeed on the presence of neuropathy. We know that in many people with diabetes, there are various risk factors for the development of neuropathy. And it's quite interesting to see that actually hypertension is one of the highest predictables of the presence of neuropathy. And this is in people without cardiovascular disease and retinopathy. So it's really quite important to remember that other factors apart from just the glycemia. Glycemia here represents itself in two ways. One, in the level of HbA1c, i.e. how well is the person controlled, but also in the sudden change in HbA1c. We all, as clinicians, sometimes see the sudden development of pain when the HbA1c improves suddenly. But largely, it's also related to duration of diabetes. As we've seen from the data presented by Professor Kaki, that even in pre-diabetes, we have people who has markers of painful neuropathy or neuropathy. So the longer duration of diabetes is really an important marker. All the guidelines, including Diabetes Canada, they are talking about what is our job in trying to address the problem. Of course, we need to prevent it by better glycemic control and hypertension. We need to screen for it because, unfortunately, in nowadays busy clinics, we do not ask the patient to take their socks and shoes off to be examined and to be screened. And there is a need for some sort of a screening program. As we have retinopathy screening, perhaps there is a call of an annual foot and painful and neuropathy screening in general. But of course, once we detect the problem, we need to start treating the pain symptoms. And the treatment largely depend on the anticonvulsants and the antidepressants. I'm not going to get involved much into how they work and why they work and what success, but I would just hint on some of the important points. But I would like you also to share the dilemma that we have as, for example, as diabetologists. When you look into the large document of diabetes management by the American Diabetes Association, you'll see that neuropathy comes only in almost one page or even less, and that painful neuropathy is a very small part of it. And largely, it describes the importance of screening and management of glycemic control, and then the treatment with the usual steps. So it is very important that we understand that reduction in neuropathy is also related to glycemic control. If we have people with well controlled, the treatment is intensified, all types of neuropathy or measurement of neuropathy will be reduced compared to those who are on standard treatment or not well controlled. But pain is not something easy. Of course, losing the pain can lead to food ulcers, and that's another type of problem. But having the pain itself is quite dramatic. Many of our patients have an average pain of 70 to 80%, whether this is American data or British data. Severe, which is in yellow here, ranges from a quarter to a third of the patients, and another 45 to 47% have moderate degree of pain. If you were to look into the burden of the illness and how does this affect the quality of life, after all, one of the important factors is prevention of mortality, but quality of life is really quite important. When you look into the person with diabetic painful neuropathy in this color, the mustard or gold color, you would see that the patients reporting problems with regard to mobility, usual activities, pain, discomfort, and anxiety and depression, they are very much higher than the general British or American population. So having neuropathy is a serious quality of life issue that affects many. When you look into the mental and physical function of a person with painful neuropathy, 60% will have difficulties to sleep. And I want you really to focus on all of these points because we'll come to them again in a different context. So having problems sleeping, consequently lacking the energy and feeling drowsy and unable to concentrate. We all experience this when we have a sleepless night for being busy on call or busy with whatever. But just imagine that this incident that you had in your life for a specific night or two is constant, is every single night. You're unable to sleep because of pain. Your energy level will be much reduced. You will feel drowsy. You will be unable to concentrate, and consequently, levels of depression and anxiety, and lastly, poor appetite. So certainly, all of these parameters that affect the quality of life of the individual with diabetes, the low mood, the fact that they say, I don't have the energy, I can't walk to the shop, I don't sleep well, I cannot concentrate at work, I cannot socialize or see my friend or in general enjoy life. So end up with low mood and low quality of life. This really is quite problematic. And the answer for all this is we have to diagnose people early enough, proactive enough, treat the underlying condition and prevent it if possible with good glycemic control and good blood pressure control. But once they have the symptoms, once they have the problem, we need to try to improve the pain through improvement of the physical function, reducing the psychological distress, and improve the overall quality of life. So it's an interaction between the biological approach, the psychological approach, and the social approach. All of this is really quite important when it comes to our pain control. So the questions about treatment are really quite important. When I sit in clinic, I need to understand how could the treatment be evaluated and what would be a measure for a good outcome. What are, for example, the international recommendations for this? And obviously, how can we tailor the treatment for the needs of every individual? So when you look into Diabetes Canada, they are considering a reduction of pain of 30 to 50% as a minimum to be considered as a clinically meaningful issue. Now, just imagine that you were to say this to your patient who has significant pain. When you say to them, I will be able to reduce your pain by 50%, it's an achievement. Although, of course, this is not meaning that you're out of pain. So basically, we're saying to our patient that you will have 70 to 50% of the pain will persist with the treatment. So the guidelines, based on the evidence and based on the ability of the drugs, are considering a significant improvement, a substantial improvement of over 50%. And I repeat again, this means that I'm saying to my patient, you will have 50% of the current level of pain at best if the treatment is successful. And that's obviously not something easy. However, for the person who is sleeping, unable to sleep most of the night, to say to them, you will have more hours to sleep, and then more increased energy level, more ability to concentrate and to socialize will be a great achievement. So part of the recommendations is obviously what we do, what we prescribe. But an important part that sometimes is missing in our practice in many places, specifically in our region, is the lack of the availability of pain services that is well established and available for our patients. And this is really one of the standard issues regarding the pain control. So, of course, we have different types of treatment for first line, but I want you to reflect when we work in our region here in the Gulf, when you have opioids to prescribe to your patients. That's not easy at all. Just imagine that you're a patient with painful neuropathy trying to travel from one country to another with a packet of tramadol, which is prescribed to you by a doctor. That will be a serious issue that maybe will put the person into serious trouble while traveling from one place to another, let alone that some of the anticonvulsants are also now being listed on drugs that can cause addiction and need to be prescribed in special circumstances. So the diabetes care algorithm for the management of painful neuropathy for people with diabetes includes, at the very early stages, when you're uncertain of what's going on, is to refer to neurology or to pain clinic. But when you're certain about that this is diabetic painful neuropathy, you proceed with monotherapy and then maybe with dual therapy, and then you can consider combining different agents. But at the end, you would need to find a source for pain clinic of a high quality. And that's a very important step that we sometimes don't find with ease in our service. Now, looking into the pooled data of the common anticonvulsants that are used or antidepressants that are used in the region or internationally, such as pregabalin and duloxetine. And you would see that the percentage of responders are coming close to the 50% target of 50% of the patients are responding to say they have improved. So another 50% response here, but how much is the pain reduced? It varies. So here you have pregabalin from 27 to 47%, the duloxetine coming close to 48%, the tricyclic antidepressants, and the gabapentin at best at 40%. So the most efficacious dose would reduce the pain by about, get with 50% response, comparable for other treatments. So really, it's quite a problem that 50% of our patients will not respond, and the level of reduction of pain is not that massive. And the same would apply to the studies that compared amitriptyline with duloxetine versus pregabalin. So very much around the same figures of all of them, kind of the same scenario here. So when you look here to the pain inventory, you would see a significant reduction by these drugs. And it's important that we remember that we have treatment that is available. But my concern is the dilemma of the patient. The patient had pain. The pain made him unable to sleep, feeling drowsy, feeling less energy, unable to concentrate, having depression, having an anxiety. Look into the side effects of the drugs itself. When you look into how many will feel dizzy or will feel sleepy or will have other side effects. So it's quite a high prevalence related side effect to the drug. The same would apply to duloxetine. Almost 20% feeling sleepy, 12% feeling dizzy, nausea. The GIT side effects of the duloxetine are more than the other side effects of the similar to the pregabalin and gabapentin. So what we're talking about here is, on one hand, the side effects of the drugs are there, and here is the problem of the patient. So on one hand, you reduce the pain, but potentially with the penalty of either dizziness or somnolence or nausea, depending on what type of therapy you would use. So indeed, the person with painful neuropathy is in catch-22. On one hand, the pain itself is damaging to their quality of life, physically and mentally, and the treatment itself is less than ideal, and the side effects are not small. So, Mr. Chairman, ladies and gentlemen, to conclude, the problem with diabetic foot is very much related to neuropathy, and many people are at risk because we are not examining enough and we're not detecting the pain early enough. Painful neuropathy in diabetes, and I'm sure in other types of neuropathy as well, is very much underdiagnosed and undertreated. Unfortunately, that the treatment, that the condition itself can negatively impact the patient's quality of life. The biopsychosocial approach in treatment is very much required. Reduction of pain by 30 to 50% is considered to be a substantial magnitude of improvement. And indeed, that would be the case. However, the level of achievement in most studies is only achieving 50% improvement. It remains that many of our patients have poor control, inability to have the available medication, and unable to get a satisfactory level of pain control. And with this, I would like to thank you for your attention, and I would like to stop my presentation.
Excellent. Thank you very much, Professor Hassan. And that was, again, really, really comprehensive and very close to my heart, being a palliative care doctor, a very holistic approach to a problem that we are seeing increasingly. In my old job in Charing Cross Hospital, I was constantly called down to the diabetic clinic to help with difficult neuropathic pain. And again, we're seeing there is a big focus on mortality being the sort of underlying final variable, but actually morbidity and its effect on people's overall quality of life is becoming more apparent. And as the world's population gets older and more patients end up with diabetes, quality of life becomes more of a prominent issue. I think that's a good starting point to move on to the next talk, which will be provided by Professor Sam El-Dabi. Professor Sam is a consultant in anesthesiology and pain relief at James Cook University Hospital in Middlesbrough. He has extensive national and international research. He is the honorary clinical professor of pain medicine and anesthesia at Durham University School of Medicine, and the visiting professor of Teesside University, and has extensive clinical and research capabilities. So I'll hand over to Professor Sam. Should be a good talk. The role of the pain clinic.
Very kind introduction. Now, what I will be talking about is the management of neuropathic pain. I have no disclosures relating to what I am going to discuss. I don't do much in the way of pharmaceutical research. This is the James Cook University Hospital where I work, and this is the area of the North Yorkshire Moors where the hospital is set. So let's talk a little bit about how we diagnose neuropathic pain. We in the pain clinic are used to most people coming in, if they report anything like a pins and needles or lancinating pain or a burning pain, then we label them as neuropathic pain. That was fine, but I think we can do better than that. So to diagnose neuropathic pain, what you need is first a patient who's presenting with a complaint of pain. That's not a very difficult thing in a pain clinic. However, when looking at the patient's complaint, it is important to assess whether the pain is in a neuroanatomically plausible distribution. So if a patient is complaining of pain in the little finger, ring finger, going all the way on the medial side of the forearm, that is the distribution of the ulnar nerve. So an ulnar neuropathy is neuroanatomically plausible. If the distribution is not neuroanatomically plausible, then this is unlikely to be a neuropathic pain. Then, assuming the neuroanatomically plausible distribution, then you have a possible neuropathic pain. You then move on to the examination. And in the examination, you are looking for signs. You're looking for sensory signs of the positive sensory signs. So allodynia and hyperalgesia are positive sensory signs. And allodynia, we all know it's pain due to a stimulus that does not normally provoke pain. So a patient with diabetic neuropathy might turn around and say, the bed sheets, when they contact my feet at night, are very painful. A patient with an ulnar neuropathy might turn around and say that touching my hand is painful. So those are all allodynia. Hyperalgesia is when a patient who has a painful foot, for example, has someone step on their foot, the pain becomes extreme. And that's an increased pain from a stimulus that normally provokes pain. Most of the patients, when they come to you, complain of what we call dysesthesias, which are unpleasant or abnormal sensations. These can be spontaneous or evoked. So this is one of the hallmarks of neuropathic pain is the occurrence of spontaneous pain that doesn't seem to be generated by something else. So having found positive or negative findings on our examination, having found both of these and these findings in a neuroanatomical plausible distribution, then we're looking at a probable neuropathic pain. Then you have the last step that you need is a diagnostic test to confirm this. This can be either an examination of an MR scan, for example, or a nerve conduction studies or an EMG. And that gives you the definitive diagnosis of a neuropathic pain. I appreciate that a lot of us may not get to the confirmatory test a bit, but it is very easy for all of us to go through to the probable neuropathic pain, and that would give you some satisfaction that you have actually got halfway or 3/4 of the way to a correct diagnosis. When we think about neuropathic pain, it's probably easier for us to think about neuropathic pain in terms of a classification. And Professor Kaki talked a little bit about the causes of neuropathic pain. I don't want to go through that all in detail again, but it's interesting to look at it from a peripheral and central neuropathic pain. The central neuropathic pains are known to be more difficult to treat, and these are generally to do with a lesion of the central nervous system, so either the brain or the spinal cord. And you can see here that the causes of central neuropathic pain are not amongst the commonest causes of pain. Peripheral neuropathic pain is more common, and it consists of either mononeuropathies, which you can see from number 1, 2, 3, and 4, or polyneuropathies, which we've heard about in the past, in the last 2 talks. So of the causes of neuropathic pain, the most common ones globally are carpal tunnel syndrome and diabetic neuropathy, as we've heard. Now, I will talk a little bit about the other causes of polyneuropathy. We know that the most common polyneuropathy is the diabetic polyneuropathy, but we will encounter in our practice patients who present with polyneuropathy for other reasons. And you can see here in the photographs signs of polyneuropathy, hands and feet, and you can see the changes in the color of the hands. You can see the wasting of the muscles. And not everybody who presents with a neuropathy or a polyneuropathy has diabetes. You can find the causes of polyneuropathy are many, and most of these people need investigating and need a thorough investigation to find out what the causes of what the cause of a polyneuropathy is. I don't propose to go through the list. You are perfectly at liberty to take a picture of the screen if you want to remember that, but it is available in most textbooks. I will concentrate, however, on the ones that are more common and the ones that we see in our practice and you're likely to see in your practice a little bit more commonly. Of those, the drug-induced neuropathies are probably the easiest ones to spot. So if you have somebody presenting with a polyneuropathy, you've diagnosed neuropathic pain, you have a plausible distribution, distal nerves supplying hands and feet, first question to ask is, what medication are you on? So isoniazid, metronidazole, nitrofurantoin are quite commonly used antibiotics. Antibiotics, we're all very familiar with these antibiotics prescribed for cancer, and you will come across them. Antivirals, perhaps these are the ones we're not very familiar with, but alpha interferon is being used increasingly. DDI and DDC are commonly used in the treatment of HIV. Other drugs that are used commonly, amiodarone, very commonly used drug in cardiovascular, colchicine, gold salt, penicillamine, chloroquine, I think has come back in fashion with COVID-19, cyclosporin. All of these are drugs that can cause neuropathies. The other common cause of neuropathies, either brachial plexopathies or single neuropathies, is cancer. And Neil would probably know more about this than I do, but we do see a fair amount of patients referred in the pain clinic for intervention because of cancer-induced neuropathic pain. This can be either tumor compression, which is the commonest cause, and here you can see a pancreas tumor which compresses the brachial plexus, and most of these people present with severe neuropathic pain in the upper limb. More rarely you get people who present with neuropathies related to paraneoplastic syndromes, or multiple myelomas. Multiple myelomas can cause peripheral neuropathies, including their treatment. However, more commonly, you get chemotherapy-induced neuropathy, and we're seeing more now radiotherapy-induced plexopathy. And this MRI shows you a very clear distortion of the fibers of the brachial plexus following extensive radiotherapy for the treatment of breast cancer. The next one you will see, I'm sure you see quite a lot of, and so do I, is the post-trauma or post-surgery neuropathies. The issue of post-trauma or post-surgical neuropathies was first raised by one of our colleagues, Bill McRae from Dundee. He was the first to highlight the number of people who continue to suffer long-term pain after undergoing surgery in the UK. And he estimated, if you look on the left-hand side here, he estimated the incidence of chronic pain after various operations from 20 to 50% after mastectomy to 85% after amputation, 55% after cardiac surgery, etc., etc. But you have to remember that from 2008 and 2006, when Henrik Kellett compiled very similar numbers, but these are for severe pain, surgery has changed, and surgery has changed quite a bit. A lot of surgery is being done endoscopically. A lot of it is being done minimally invasive surgery. However, certain types of surgical procedure, particularly breast surgery, thoracotomy, and inguinal hernia, continue to be associated with a high incidence of neuropathic pain, regardless of the approach. Amputations, of course, that has not changed, and the incidence of neuropathic pain or phantom limb pain post-amputation remains quite high. The question, I suppose, is how many of these patients will be disabled by severe pain? And the study by Henrik Kellett on the right-hand side of the slide shows you that the number disabled by post-amputation pain are not small. They go up to 10% after amputation, 10% after thoracotomy, 10% after coronary artery bypass surgery. One of the more common surgeries that you will come across, of course, is lumbar spine surgery. Lumbar spine surgery is on the rise, no doubt, in the UK, US, and in the Middle East. We did a study in the UK a number of years ago now, looking at asking the question, what is the incidence of persistent severe pain after lumbar spine surgery in the UK? And I won't bore you with the details of the study, but we found that 1 in 5 lumbar spine surgery patients will continue to have severe pain after lumbar spine surgery. So these people present with pain and go out with more severe pain. And the 20% incidence we found was the most minimum estimate. It is likely that the estimate is bigger than 20%, but that's another story, another lecture altogether. So let's look at the pathophysiology of neuropathic pain. Neuropathies in general present with, if you look at the slide presents with, you can see the dorsal root ganglia where the bodies of the sensory neurons are housed, and here are the axons. So in a condition like diabetes or a degenerative polyneuropathy, ischemia of the axons is the primary pathology, followed by demyelination, axonal degeneration, failure of the function of the Schwann cells. However, in a traumatic situation, you will have a complete disruption of the axon, followed by Wallerian degeneration. Dr. Hassanin, or Professor Hassanin, spoke quite a bit about the consequences of painful neuropathies, from sleep, mood, etc., etc. And when you look at the treatment of a painful neuropathy, your target is not just the pain, but it is the pain and the whole individual, as we've heard before. The sleep, the mood, the functional capacity, the quality of life, and preventing the progression of the disease and preventing the consequences of a neuropathy are quite important, because these will impact on the quality of life of a person quite significantly. Now, we've talked a little bit, you've seen the drugs that are used in painful neuropathy. There are 3 classes, as Professor Hassanin has mentioned: tricyclic antidepressant, serotonin and noradrenaline reuptake inhibitors, such as duloxetine and venlafaxine, and the gabapentinoids. Pregabalin and gabapentin, which I'm sure you are very familiar with. Professor Hassanin also showed you this very much recommendation for algorithm for the treatment of neuropathic pain, which is not dissimilar to what he showed is the NICE guidance, except that there is a change in the NICE guidance regarding neuropathic pain, and this is that box here: avoid opioid analgesics. So although about 2 or 3 years ago, we used to say that opioid analgesics are recommended for long-term neuropathic pain because, in fairness, they do work, we now recognize that they do work, but for a short period of time. And in the long duration, in a person who has chronic neuropathic pain, opioid analgesics, the tolerance and the side effects and the potential for addiction make opioid analgesics not a very good choice. So you're left with a choice of either the anticonvulsants, gabapentin, pregabalin, serotonin, noradrenaline reuptake inhibitors, duloxetine and venlafaxine, or tricyclic antidepressant. Which one do you start with? And I tell you that it's not really a problem which one do you start with. You can start with any of the 3 classes. If you fail with that one, you move on to the 2nd class. And if you fail with the 2nd class, you move on to the 3rd class, or you may choose to combine 2 drugs together if that doesn't work for you. Now, I I would like now to concentrate a little bit on pregabalin and gabapentin, because in our practice, these are the two most commonly used drugs. The drugs have been reclassified in the UK, and I'm sure where you are, into Class C drugs that need to be accessed via special precautions. That has happened only last year in the UK. This is a review of pregabalin and gabapentin that we published in the British Medical Journal only earlier this year, and it provides you with a fairly decent overview of how good are these drugs. So pregabalin is, as you can see here, is licensed in the UK for central and peripheral neuropathic pain. Gabapentin is for peripheral neuropathic pains and post-herpetic neuralgia, diabetic neuropathy. In the US, it is slightly different in that it is also licensed for fibromyalgia and neuropathic pain of spinal cord injury. Now, let us look at the performance of these two in case of neuropathic pain. This illustrates fairly simply what Professor Hassanein talked about, effectiveness. How effective is pregabalin in the treatment of a peripheral neuropathic pain? So the green are people who will get 50% pain relief. The black people are those who will not. So 41 out of 100 patients will get 50% pain relief if prescribed for diabetic peripheral neuropathy or post-herpetic neuralgia at 600 milligrams a day. Well, it's not bad. 40 out of 100 is not brilliant, but not too bad either. Now, let's talk about the harms of these drugs. How many will get adverse events? Now you get a completely different picture here. So the blue are the ones who will get adverse events. The reds are the ones who will get serious adverse events. And the orange ones are the ones who will become addicted to the drug. The black are the ones who are not affected. So you can see that the number of people not affected by long-term treatment with pregabalin is not huge. They're not the majority. As a matter of fact, the majority will experience an adverse event or other. The number who will experience a serious adverse event are smaller, but a small minority will become addicted to this drug. So let's see how gabapentin fares. Gabapentin is slightly worse in effectiveness. So 38 out of 100 people will get 50% pain relief. And the picture in adverse events is quite similar. 63% will get adverse events. About 3 or 4 will get serious adverse events, and 1 will become addicted to the drug. So what are the adverse events? The adverse events of pregabalin and gabapentin are not serious, but are problematic. So dizziness, somnolence, difficult concentration are what most people report. So although a lot of people will get an adverse event, it may not be a serious one, but gait disturbances are particularly serious if you're prescribing this for an old person, because a gait disturbance might cause them to fall and break their hip, which is worse than the illness they came to you with in the first place. So why were gabapentinoids classified or reclassified in the UK as a Class C drug? And I'm sure this is going on around the world, that people are becoming more cautious of gabapentinoids. Largely because the prevalence of gabapentinoid misuse is on the rise. They are not in themselves a primary drug of misuse like opioids. Largely, gabapentinoids misused is very high in people who are already misusing opioids. It is a problem for opioid addicts. Isolated gabapentinoid misuse is actually much rarer, and it's 0.5 to 1%, as you've seen. However, if you are going to co-prescribe opioids and gabapentinoids together, the risk of drug-related overdose and death, accidental or intentional, rises to 1.5 times the original risk. So again, these drugs are not to be prescribed lightly. If you prescribe someone gabapentinoids for neuropathic pain, you have a duty to follow them up and see whether do the drugs make a difference. And if they don't make a difference, you need to slowly taper them and stop them. Stopping gabapentinoids suddenly is not recommended because of the risk of convulsions. So it is important to ask the patient about, are the drugs effective? Are the drugs not effective? And if they are effective, does the patient have side effects? And how do they view the balance of the side effects against the pain reduction? Now, most commonly, gabapentinoids are prescribed for complaints of low back pain and sciatica. Recently, there are two studies that have been published, one in 2016 and one in 2017, comparing gabapentin pregabalin to placebo. And unfortunately, both did not find any difference between the performance of either pregabalin or gabapentin to placebo. This was in acute and chronic sciatica, and that one was in chronic low back pain with or without sciatica. So on the whole, prescribing gabapentin and pregabalin for low back pain and sciatica is something that a lot of people do, and you can understand why in the face of not many effective drugs for these conditions, people get to this point. However, again, if you are going to prescribe it, keep in mind that the studies don't support this, and therefore, if it doesn't work for your particular patient, it is useful to follow up and to discontinue the medication if the patient finds it not effective. So, as an introduction to Professor Buxer's story, I will talk to you about what else do we offer in pain clinics. You may be familiar with the term neuromodulation, which is the changing of a nerve function through the application of a drug or an electric current. And it has many uses. Neuromodulation has hundreds of uses, that some of them are very well established, like deep brain stimulation or cochlear implants for the treatment of deafness, vagal nerve stimulation for epilepsy or depression, spinal cord stimulation for the treatment of pain. There are many uses for neuromodulation, of which I will concentrate on spinal cord stimulation for the treatment of neuropathic pain. So what is spinal cord stimulation? Simply put, it is the application of an electric current to the large diameter fibers in the dorsal spinal cord. How do we do that? You do that through the implant of a pacemaker-like device, which consists of a battery, you can see here, and wires that sit in the epidural space of the spinal cord. These wires can be connected directly to the battery or may be connected to via an extension. So here you can see how a current applied into the dorsal column of the spinal cord might propagate upwards and downwards from the point of current application and can produce a signal that can be measured distally. This is called an evoked potential, or an evoked potential caused by the stimulation, and that you can measure and you can quantify. So here is the clinical application, and you can see here the X-ray of the battery, and you can see how the wires progress into the epidural space. The electrodes are these small dots that are the electrically active parts of the wire, and here you can see the same arrangement but in a lateral view. So how does spinal cord stimulation work? If you recall from the the small video that you showed earlier on, the current propagates upwards and downwards. So if we were to think about the current propagation downwards, which we call an antidromic, because that's against the direction of nerve conduction. So you have a current that propagates backwards into the dorsal horn of the spinal cord against the natural flow of nerve pulses. And this stimulates the inhibitory circuitry that is present in the dorsal horn of the spinal cord, causing segmental inhibition of the transmission of pain. And that's the main mechanism. However, we also have an orthodromic transmission, which is traveling with the direction of nerve fiber transmission, and that activates circuitry in the brainstem, resulting in descending inhibition. The descending inhibition acts upon the dorsal horn to further stop the transmission of painful impulses into the spinal cord. So there are two ways you can inhibit transmission of pain and its conduction into the spinal cord. One acting directly on the dorsal horn, and one acting on the fibers that descend from the periaqueduct gray and the brainstem to the dorsal horn, where they also activate inhibitory circuitry. With that, I will hand over to Professor Buxer. Thank you very much. And if you have any questions, please do not hesitate to get in touch with me by email.
Thank you very much, Professor. That was, again, a really, really excellent overview and a lovely introduction to spinal cord stimulation, more practical sides of neuromodulation. We will move on to Professor Bücher's talk. Professor Eric Bücher is a professor in anesthesiology, and he is the senior consultant at the Department of Anesthesia, Pain Management and Neuromodulation at the Hospital of Morges in Switzerland. I'm going to hand over to Professor Bücher for the last presentation of the evening.
Thank you very much, Dr. Neil. All right. I'm from Switzerland in Morges. This is the hospital where I'm working, which is along the shoreline of the Lake Geneva, as they call it, which is actually much closer to Lausanne. I have no major disclosures, though I have the same problem than Dr. Kaki here. The slide is very slow. My department has received research funding from the Swiss National Foundation, from the Federal Commission of Technology and Innovation, as well as some research fund from Medtronic. And I'm currently a consultant for Medtronic as well. I have, however, no financial interest or share in any company. So if we focus on spinal cord stimulation, I would like to share with you the initial observation. That's 20 years ago. We soon realized that spinal cord stimulation does relieve neuropathic pain, or can relieve neuropathic pain. However, it has no effect on nociceptive pain, and the effectiveness of spinal cord stimulation is decreased or even absent in areas where there is a sensory loss. Furthermore, there is a somatotopographic coverage of the pain with the paresthesia that is, or at least was deemed to be necessary. In other words, if you do not cover the area of the pain with stimulation, paresthesia elicited stimulation, the chances of success is much lower. Here is just a figure of a very early data that's been published in patients with diabetic polyneuropathy. I think that the interesting thing is that whether it is the background pain or the peak pain, you see that this level up here is the pain without the stimulation, and down here is with the stimulation on. And this is observed at 3.3 years, and even 7.5 0.5 years later. The number of patients is very low, but I'll show you some data further on that is more convincing. Back to the paresthesia distribution. If here the area of pain is the red area that you can see here, and if you put those electrodes with any kind of stimulation or contact that you stimulate, you may cover part of that. Now, this is the area of paresthesia, but what we have considered for a long time, that if you don't have paresthesia, if you don't cover your pain with paresthesia, there is no pain relief. Well, this has been shown not to be exactly true, because over the time, it has been shown that subperception stimulation, particularly in neuropathic pain, but in vascular pain as well, does have an effect. And this has been shown by Volter and co-worker, where although the efficacy may be decreased, there is certainly some clinically meaningful effect, even though if you do have paresthesia that you cannot feel, and this is the middle box here. This is the only slide I'm going to show you on the vascular effect. Now, it turns out that spinal cord stimulation profoundly affects the vascularization of the periphery. Here is what happens in a thermography in the lower limbs, and you see that compared to the control, after 5, 8, and 20-minute stimulation, the thermography increases very much with the paresthesia. But you can see the same thing without the paresthesia. And that's the first aspect. So no paresthesia does not necessarily mean that you have no effect. Now, the other thing is that once you started the stimulation here in the hands, you have a very quick effect, but when you stop the stimulation after 20 minutes and wait another 20 minutes, you can see that there is a persistent effect. So spinal cord stimulation, although there is, in most cases, particularly in diabetic neuropathy, the effect tends to be rather short-lived when you stop it. You can have an effect that is much more persistent. Now, back to the paresthesia-free stimulation. There are a number of ways you can get paresthesia-free stimulation. You can first have a subthreshold stimulation or high density, which is another, I don't want to bore you with the technicalities, but there's another stimulation mode, high frequency, just increasing the frequency of stimulation, or burst stimulation. But see, the problem is, the problem is that all those modes of stimulation have shown some efficacy that was either similar, better, or worse than conventional stimulation. In other words, the stimulation that you have when you stimulate the nervous system at frequency up to 150. But those results depends a lot of the type of pain, but mainly to the manufacturer who's paying for the study. And this has become a very difficult problem in the area of neuromodulation, that because of the fierce competition between the companies, it is often very difficult to find the proper science that may get you to the knowledge that you want to have. Now, back to the indication for spinal cord stimulation. The most prevalent indication is the neuropathic part of failed back surgery syndrome. I'm not going to go into the details of the failed back surgery syndrome. You know that, but this is the main indication worldwide. Complex regional pain syndrome is the second one, but that depends a little bit what the geography you look at. Polyneuropathy is probably the indication that is least used today. First, failed back surgery syndrome. Now, here is a study that's already very old, but what's interesting is the first study that has actually been a prospective, randomized, controlled, multicenter study that looked at the effectiveness of spinal cord stimulation versus conventional medical care. And it's an interesting study because it has a reasonable sample size, 100 patients, and it looked at 6 months, which is the primary outcome. 6 months being what we looked at, the primary outcome was a 50% decrease in the leg pain. You know, those patients often have both leg and back pain, but this study was looking at the leg pain. 12 centers in Europe, Australia, Canada, and Israel. And the conventional medication was up to the physician. Now, what happened? Well, this is looking at 6 months. You see, this is the percentage of patients who achieve at least 50% decrease in the pain decrease in the leg. Now that's close to 50% at 3 months, a little bit over 55%, decreases to around 50% at 6 months, and those results are persistent at 2 years. Now, the interesting thing is that compared to medical management, only 9% of the people who are treated without spinal cord stimulation do achieve 50% pain decrease in the leg. So the reasonable conclusion from this study was that indeed spinal cord stimulation is more effective than conventional medication. Now, the question is, how about reoperation? And here is a study that comes from the US. Rick North has done this study, where in a single center study, they randomized patients after a first operation. Patient came back, pain was not improved, and they randomized them into either surgery, second surgery, or spinal cord stimulation. 6 months later, those patients had the option to take the other alternative. So if you look here, those who did not get 50% pain relief, 30%, 37%, nearly 40% of those who had surgery opted to go for spinal cord stimulation. And those who had surgery, only 11%. So clearly, spinal cord stimulation had a much better outcome. Now, the other thing is they looked at the increased opiate consumption. And you see here that those patients who had only surgery increased considerably their opiate consumption compared to those who had stimulation. So again, comparing spinal cord stimulation to reoperation, the spinal cord stimulation comes up very profitably against the operation. I've told you that there are new ways of stimulation. And here is one example. This is a very well-known study stimulating at very high frequency. And you see they have a very dramatic decrease of pain, both in the lower back and the leg. Now, when this study was repeated by a group that was not sponsored by the company, here are the results. So the overall back and leg pain was virtually unchanged if you compare the high frequency and the spinal cord stimulation. That is not to say that either one or the other of those studies is right. This is only to illustrate that we are in a situation where the pressure from the industry is considerable. And in order for us to have a proper evaluation of the treatment, we have to be very, very careful. Now, how about the healthcare cost? Well, if you compared spinal cord stimulation to conventional management, there is a cost neutrality that is reached between 15 months and 5 years, which means this is already an old study, but there have been other studies that confirmed exactly that, which means that overall the stimulation is cost effective. The second big indication for spinal cord stimulation is complex regional pain syndrome, which is this pain that arises either after surgical trauma or even after a very minor trauma, and can have devastating effects. Here is, again, a study that came out in the New England Journal of Medicine in 2000, that compared patients with complex regional pain syndrome to who received either spinal cord stimulation and physical therapy, which is the only treatment everybody agrees patients should have, to physical therapy alone. They looked at 6 months, 2 years, and I'll show you 5 years or 5 years result. What they looked at was really the pain. Interesting here is that at baseline, you see that both groups, the pink one is physical therapy alone, and the red one is stimulation plus physical therapy. Now, the interesting thing is that they have randomized 2-to-1, 2 patients for the stimulation and 1 patient for the physical therapy. And the reason for that is because not everybody will respond to the spinal cord stimulation. You see here that about 60% patients responded with an average improvement of 40%. So over time, you see at 1 month, there is a significant decrease here of the SPEN score in those patients who had both stimulation and physical therapy, and that was maintained at 6 months. Now remember, this is a study that was analyzed in an intention to treat, which means that a significant proportion of those patients in the red columns are considered having had physical stimulation plus physical therapy, but if they failed the stimulation, they still counted as they would have had the stimulation. So this was considered to be very significant. And if you look at the global impression of change, you see that those patients who had the stimulation as well as physical therapy had an increased effect and rated it as either unchanged, improved, very much improved. Nobody was best than ever, but one of the physical therapy alone was worst ever. So again, the global impression change is a good measure of how you affect the quality of life. Now, you've seen that the initial study has been published by the New England Journal of Medicine. And what happened is that the journal requested an overview at 5 years. They wanted to know whether this patient group actually had a maintained effect. So the authors wrote a letter with the reference of which is here. And what they saw was that actually you lose the effect after 2 years. Now remember, the design of the study was to look at 6 months. So it's difficult to expand the interpretation to 5 years. Besides, if you look at physical therapy plus SCS, 31 patients had that. 11 of those were not implanted. This was in the red, and this is what remained from the intention to treat design. If you just look at the spinal cord stimulation plus physical therapy, that's in 20 patients that were implanted, and you see that the VAS score remained very low, even though at 5 years it tended to increase. The globally perceived effect, again, was much better in those patients who had the stimulation than the other, right? If you ask them, would you do it again? 95% of the patient would say, yes, I would have the treatment again. Whatever that is, whatever value that has, I don't really know, but at least it's an indication, indirect indication that the treatment is effective. Now, the problem you see with that data is what the data shows is that after 3 years of follow-up, there is no statistical difference in VAS. In patients that randomized, they're randomized, not the ones that have got the treatment, randomized to spinal cord stimulation and physical therapy. They don't mention that the effect persisted in those patients who had the stimulation. So what the critic will remember is that SDS does not work in CRPS. And more importantly, what the payers understand is CRPS is not cost effective. So don't fund it. Now, if you do have time, I would very much recommend you go to this reference here. It's a paper written by Daniel Carr, who probably a number of you know already. It says, when a bad evidence happens to good treatment, and it's a very good analysis of what the fallacy of evidence-based medicine can be. However, if you look at the pain score overall, the different study that made, it shows that the weighted mean difference is clearly in favor of the stimulation. Same thing with cost effectiveness. The health economic analysis shows that spinal cord stimulation is more effective and less expensive over the long term. Most European governments or health authorities would pay up to 20 to 30,000 euro per increased quality adjusted life, and so with the spinal cord stimulation for CRPS, we are clearly within this target. Incidentally, it's been recommended by NICE that has accepted it. If we go now to the painful diabetic neuropathy, this is I think it's the first publication that appeared in the Lancet. And they had 10 patients who were unresponsive to conventional therapy, 6 patients with diabetes type 2, a mean duration of diabetes of 2 years. And what they did was a very elegant design. They trial stimulation, crossover, and blinded. 4 days of test, 2 days stim on, 2 days stim off. And if the patients had more than 50% relief, they would implant the stimulator with a generator. So they looked at the decreased pain, the peak pain at 3 and 6 months. 8 out of 10 patients responded, and you see here, if you compare peak pain in red to the baseline, they all responded, as well as the background. So that shows that actually this system was effective in this small group of patients. What they also showed was that patients would increase their exercise capability. So functionally, they would increase in treadmill exercise, both at 3 and 6 months. And I will come back to that later on, show you some of our own data. There are at least 2 studies you have to be aware of. The one is the one from Cécile de Vos, that is a multi-center study which united 7 centers with a parallel design, 2-to-1 randomization. And to cut the long story short, what they showed that the VS scores was clearly decreased. And here you have the dark bar are spinal cord stimulation. The light bars are just the control. So you see that at 6 months, there is a very significant improvement. The other study, which is also a randomized control study in 36 patients, that's I think is a 2-center study. Again, what they showed that was that compared to the best medical treatment, at both 3 and 6 months, you had a significant decrease in both daytime pain and nighttime pain, which is a very difficult problem in diabetic polyneuropathy, as we've heard before. Long-term effectiveness is also has been looked at from one of the authors, Langen, who just was the author of the study, just I've showed you before. And you see that if you go up to 36 months, you do have a daytime pain intensity that is reasonably stable and remains low or lower. And equally, the quality of life, green here, is substantially increased over the same period of time. So in painful diabetic neuropathy, spinal cord stimulation is effective. Here is a paper that will appear in Neuromodulation. It's just a preview. And they looked at all the different modalities that have been applied to treat diabetic polyneuropathy. These are the number of patients they've looked at, and they looked at the duration. So there may be sometimes with a very small number of patients, but you see the results are pretty consistent with a significant decrease. If you look here at the only 2 randomized control studies that I've showed you, the mean weighted difference is clearly in favor of spinal cord stimulation. The problem with this indication is that it has not been shown yet to be cost effective. In other words, the cost of one quality adjusted life is far beyond what most government are willing to pay. Now, the problem is not necessarily that it is a problem with the technique, but if this data has been published and looked at a cost effectiveness at 12 months, obviously the procedure, the implant, and all the equipment will burden very much the cost because of this initial investment. And that might be leveled out if we look at longer time duration, but it is not clear yet. As I told you, NICE has actually endorsed the spinal cord stimulation for neuropathic pain, provided there was severe pain, that the assessment was done by a multidisciplinary team, and there was a successful trial. Now, I've showed you one of the studies, the earlier study, that showed that people actually improved their physical activity. What we did was looked at this in great detail with physical activity monitors. This is the size of one of those, patients were carrying 3, one in the thorax, one in the thigh, and one in the calf. And you could differentiate sitting, standing, lying, and walking position. So if you look at what happened to people with spinal cord stimulation, there were different diagnoses, but overall, they considerably increased their walking distance. Now, I want to point out that this is percentage of change. 450% of nothing is still not very much, but overall, it indicates that you do have a clear improvement. They did improve the time they were standing and walking, and the time they were lying was decreased, as well as the pain score, obviously. Same thing with the speed of walking that became that increased, and the variability of the speed decreased, stride length the same. This all goes towards a better, the indication of a better and more safer gait, decreasing the number of falls. Now, shortly, the selection criteria for spinal cord stimulation, you need a clear diagnosis of neuropathic or possibly ischemic pain. You can't do that if you have patients with upper and lower limb involvement, because you can't reasonably cover the whole body with stimulation. You must have an insufficient response to conservative therapy, just because if you get away reasonably well with a few pills, I don't think implanting a stimulator makes any sense. No insignificant unmanaged psychological issue, substance abuse, surgical intervention that are not indicated, that the patient had repeatedly, that sort of thing. The successful screening was required, still is required to the far as I know, by NICE. But there is a paper that will come out. Professor El-Dabi is the first author of that, and they actually showed that in well-selected patients, the trial stimulation is probably not cost-effective. Now, no significant unmanaged psychological issues. Now, what is this? Sorry. Well, it's a bit short, but you can't just go on your gut feeling and say, well, he or she is or is not crazy. You need a proper psychological evaluation. Now, the point with the psychological evaluation is that it is not designed to find the ideal candidate. In other words, you do not look for the patient that is like this, that would fit like that. What you do, or what the psychological evaluation can do for you, is actually make sure that people who are not suitable for spinal cord stimulation are rejected. And you end up with a scoring comparing either the three signals. Green is go ahead, proceed with the treatment. There is no problem. Or yellow, which is proceed with the treatment, but psychological sessions will be required pre as well as post intervention. And red, don't touch it. There is a severe psychiatric problem. Now, just to finish that on the complications, well, like with any therapy that involves technology, there are hardware complications, lead migration up to 23%. Now, this number has actually decreased with the availability of new and more modern equipment. Battery failure rare and have become even more rare now. The biological complication, the pain at the implant site can be up to 31.4%. People will complain of pain around the stimulator. Now, this can be very difficult, and this has led to the explantation of some people that had successful stimulation. The infection, well, in recent series, 2 to 3%, but this was much higher in earlier series. Interestingly, but this is a retrospective study, so it may be difficult to assess properly, but diabetes, obesity, and smoking history may not be a risk factor for infection. Now, the therapy-related complication, now, this is relatively uncommon or even rare. There is one problem that occurred with a new mode of stimulation that targets the dorsal root ganglion, and that was associated with an increased number of dural puncture or neurological injury, that to the extent that the treatment was put on hold in Denmark. So in conclusion, to compare spinal cord stimulation to the best medical treatment, it provides a significantly and clinically meaningful improvement in patients with neuropathic pain, whether due to failed back surgery syndrome, complex regional pain syndrome, or diabetic neuropathy, or other neuropathy for that matter. It improves the quality of life. Cost effectiveness is well established for FBSS and CRPS, and may not be so for diabetic neuropathy, at least not yet. It may improve the vascular problem, but complications are not uncommon, and the hardware are more common than biological. Serious neurological complications are very rare, but nevertheless, they do exist. And with that, I thank you for your attention, and I'm ready for any questions that will come.
Thanks very much. So that was excellent. That was a really lovely overview. Almost felt as if I was back in medical school. So we have come to the end of this very short and focused webinar on painful neuropathy. We have a total of 71 participants, and either everyone's very tired or very shy because we haven't had any questions yet. But I can certainly start things off. And if I can start with Professor Bücher's talk, your comment about the time, given the time frame to cost neutrality. I had sort of two questions to that part. One, what does the evidence show? What's the longest these devices have ever been implanted for? And then secondly, what's the relevance with palliative care, given the typically shorter duration with shorter life expectancies?
Yeah, well, the answer to your first question is the data show for failed back surgery, at least, and CRPS to some extent as well, that you do reach a cost neutrality at about 4 years, which means that the cost of conventional treatment at 4 years is higher than spinal cord stimulation, which obviously is not the case if you look at 12 months. To the second part of your question, which has to do with palliative care. The problem with palliative care is that it is relatively rare that you do have a patient with localized pain. And when the pain is not localized and is not in, both legs or one arm, and it is very difficult to cover with spinal cord stimulation. And if you do have And I have the same experience that you have. You get those patients with cancer, with other ailment, with neuropathic pain in an environment of terminal care. I believe that most people would agree that spinal cord stimulation is not a good option. Most of us would go for implanted pumps. And I don't know how popular that is with in the Gulf region, but we are using a lot of clonidine for the treatment of neuropathic pain.
Okay. Professor Kaki, did you want to comment or make any comments about the last statements about the clonidine use and pumps?
Yes, regarding clonidine, is not that popular actually in the Gulf area. But yeah, I have tried it before in North America. It works well. For palliative care, we're still using some implantable pump, and we go mainly for opioid morphine for that.
Okay. We've actually got some questions. So we've got some participants asking about, I guess, the relevance of lidocaine patches, lidocaine infusions, and ketamine in neuropathic pain. These were directed to Dr. Sam. Unfortunately, Professor Sam had to leave for family reasons. So I'll open that question to faculty, please.
Yeah, I'll take care of that.
Okay.
We could use it if the neuropathy is localized. You could go for lidocaine patch, but we cannot apply it for diabetic neuropathy. With both lower limb is affected, and we know that lidocaine is limited to 4 patch. So it's not more than that. You cannot put a lot of patch on one patient and then you induce toxicity. Regarding the use of infusion, we are using lidocaine infusion, ketamine infusion. Lidocaine infusion, we go for 3 to 5 milligram per kg, sometimes up to 7 milligram. We run it slowly. There's no contraindication for that. The patient has no cardiac rhythm abnormality. You cannot apply it for somebody with cardiac block or cardiac failure or something like that. And ketamine also has been used. And we use a very small dose of 20 mic, 5 to 20 mic per kg per hour as an infusion. Usually, I like to mix both together with magnesium, and it helps. In some cases where it's difficult not responding to conservative therapy and the patient cannot offer spinal cord stimulation, we offer lidocaine, ketamine, magnesium infusion every 2 weeks or so.
Okay, excellent. We haven't got another one, but I've got sort of slightly different questioning, and this is to some degree showing my relative newness in the Gulf. I've only been in the UAE for just over 6 months, and one of the things I have noticed is that actually, again, this is anecdotal, I have no data, that we generally seem to give our patients, or our patients generally tend to use lower doses of opioids than I see in the UK or the US or the Caribbean, where I've worked previously. Have you noticed the same phenomenon?
Yes. I totally agree with you. For the Gulf region, we are going with a first small dose of opioid, first small dose of gabapentinoid, and even duloxetine. And I don't recommend what's written in the textbook for the people in the Gulf region. If you talk about pregabalin, I like to go with 75 once at bedtime for a week or 2 before I increase the dose. Because most of the patient here, once he starts to develop the side effect, he will stop the medicine. And he will say, this is a bad medicine, I don't like it. They're all like that. So start slow and gradually increase.
That's a good motto. When I was working in the Caribbean, again, doing purely palliative care, one of the things I noticed was that I couldn't start patients. I would normally start somebody in the UK on 75 at night, then BD. I just could not do that with a group of patients in the Caribbean. I had to start with 25 of pregabalin. Are you noticing the same phenomenon?
Yeah, yes. Unfortunately, we don't have 25 here in Saudi.
Correct.
In some other GCC country, but I agree with you totally. Yeah.
And if I may comment as well, is the current dilemma of the duration of the prescription. So now our patients need to come for a monthly prescription, which obviously make the adherence and the compliance of treatment pretty low.
Correct.
Yeah, that's another issue.
That is another issue. Professor, can sorry, this is to Professor Hassanein. I can't remember whether it was one of your slides or Professor Kaki's slides regarding central post-stroke pain. In my current hospital, we have a lot of post-stroke patients, a lot of stroke patients post-COVID. And there seems to be a high significance of sort of what I would call thalamic pain, post-stroke thalamic pain. What I've looked at the evidence recently because I've been having problems, but you're probably more familiar with it. What is the first line and second line for that?
Okay. Want me to go first, or Mohammed, you want to go first?
No, you go first. You go for it because it's not part of my wasn't part of my presentation.
That's fine. Yeah, we know that post-stroke pain, the central neuropathic pain, actually is one of the difficult ones to control, unfortunately. And here you have to individualize the treatment. You know, some of them, they have a good response to high dose of gabapentinoid or duloxetine. Some they don't. Sometimes you need to induce opioid. And I like to use the tramadol or tapentadol, which has some serotonin, norepinephrine reuptake inhibition with mu effect. And in most of the patients here in this part of the world, they are so naive to opioids, so they have a good response to that. Yeah, unfortunately, we don't have the deep brain or stimulation or other. Yeah.
Okay. And Professor Hassanein, leading on from that, we see a very high proportion of our patients with quite severe diabetic foot. Either my clinical acumen has decreased, but and we've got about, I would say, of a total of 60 patients on our long-term care ward, we have 10 with horrendous diabetic foot. So 6 of those patients, none of them have neuropathic pain of any sort. Are you noticing, are you seeing the same trends that we see in the UK in the Middle East area, or are you seeing something slightly different?
I honestly don't have data of comparison because as you rightly said, the data, and Professor Kaki presented the prevalence. The prevalence of neuropathy is very poorly measured. It depends on what center you're in, on what methods of testing, whether it's proactive or you're waiting for people with symptoms. It's very much related, for example, to the 20 years ago about the era of erectile dysfunction, that the patient doesn't discuss and the doctor doesn't discuss because treatment is not satisfactory.
Sure.
The current situation with the painful neuropathy is more or less the same. The doctors are so busy focusing on the renal and the cardiovascular aspects of things, and because of the frustration with the pain control management, they are not proactively looking for it. So we end up with the person, and even if you look into podiatry service for foot problems, it's the item of a podiatrist does not exist very much in the Gulf region. In some even circumstances, it is not as a classified job. So you don't really know. I mean, the number of podiatrists in the region are very, very low. And the centers that are dealing with diabetes are really trying their best to get more of them and to get training for podiatrists and accreditation for podiatrists so that they can progress in career. So no doubt you end up with different problems. But I would like also to share that the rates of smoking in the region is much higher than UK. So perhaps you're seeing more of the vascular end of the problem rather than the neuropathic part of it.
That's true. That's true. Yeah, no, that's a good point. I think I could ask questions all night, but actually, the only other question that we have on the Q&A session is, actually, no, I've missed it. We've got one question here saying, is anginal pain, which is resistant to conventional treatment, a neuropathic pain? And would you implant a spinal cord stimulator for angina? I'm not sure that you would do that.
Yeah, well, actually, it's a dream indication. It has a very, very high success rate. There's not old, I think it's been published in 2002, a randomized control study comparing spinal cord stimulation to cabbage in patient with in patient who had already had an operation and were not expected to have a complete revascularization. And interestingly enough, the success rate of spinal cord stimulation was exactly the same as the cabbage. And the complication rate was, of course, much lower. And it is quite true that spinal cord stimulation for the control of intractable angina, whatever that means, is an extremely good indication. Now, there is one thing that may have changed since then is the fact that the cardiologists have become much better, and they have more stents to their disposal. So that may have changed a little bit the picture. But to the question, is spinal cord stimulation a good indication for angina? Definitely, yes, it is.
Okay. Excellent. And we have, I think people have become a little bit braver. We've got a couple more questions. Very quickly back to Professor Kaki. You mentioned tapentadol. We've got a participant who's asking whether tapentadol is available in Saudi Arabia.
Yes, it's available since last year, but it's in limited center. Unfortunately, it's not yet distributed throughout the kingdom. No. Okay,
all right. The next question is and again, this is quite a broad, so you may want to share this one. What is the role of neurolytic nerve blocks in chronic pain?
Now, we like to keep neurolytic block, mainly if we are using phenol or alcohol or glycerol for cancer patients. We don't like to do it for non-cancer cases, particularly for palliative care. But in neuropathic pain, mainly the diabetic one, if we need to do some sort of neurolysis, I prefer to use the pulse radio frequency, where you don't harm the nerve, but you have the same effect. It might last for a shorter period, but it gives the patient a relief at least for up to 3 months.
Okay. Can I ask? I think we're probably almost running out of time, but I was going to ask about the use of ketamine and burst ketamine in patients with quite severe neuropathic pain that doesn't respond to opioids, or patients are intolerant to the opioids. What's your experience?
Yeah, it does work, actually. It does work, and I have seen its effect mainly among secular, and I'm sure that you face that in the Gulf region. Some of them, they have a very bad neuropathic pain, and if you put them on a ketamine infusion for a day or two, they get a very great response, actually.
Okay, and that's certainly in palliative care, we tend to use more homeopathic doses, shall we say, relative to my pain specialist. But I would generally start with 50 milligrams in a day. What's your typical starting dose?
I start I like to go with the mic per kilo, so I start from 5 microgram per kg per hour. Yeah,
okay.
It depends on the response of the patient. Yeah.
Okay. And I believe, I think that's all the questions that I can see in the Q&A session. Well, there's one more here. Somebody's asking whether neuropathic pain is a specialty or is a discipline for pain doctors or neurologists. I don't know if anybody wants to fancy answering that.
Neuropathic pain is a complex one. It needs a multidisciplinary, multimodal treatment, so they both share in the treatment.
Yes, I agree. And I think I would reiterate, this is, there's so many parallels with all the presentations today focusing on, holistic approach to both symptom assessment and treatment and management of the condition, without losing sight of the fact that we may get very excited about the different medications and interventions, but there's a patient at the end of all of this, and we mustn't lose sight of that. We've had a couple of questions about asking for the copies, PDFs of the presentations. I don't know whether we're allowed to, or whether presenters are happy to share those.
Sure, no problem.
No problem, excellent. And then the last thing to bring up, unless there are any more questions, is that CME is provided and mediated by the Dubai Health Authority. And the process for this, like many other clinical webinars, is that there will be a questionnaire for you to fill in regarding the webinar and feedback. Once that's submitted, there'll be a sort of a roughly 2-week turnaround time for the CME accreditation to be processed, approved, and then disseminated. And I think we were due to finish at 10:15, so we've got a couple more minutes. Someone's just asked whether some radiologists claim that they can treat chronic pain. Can they?
Well, the problem is, you see, the problem is that treating or alleviating pain for a short time is very easy. Anybody can do that. Now, whether you do procedure or you don't, one of the very important things is that you follow patients.
Correct.
Now, at least in my environment, radiologists are not the ones that are doing that the most, with the most regularity. So they do the block, and that's it. And I think that if you just simplify the treatment to blocks and needles, I don't think anybody's treating chronic pain.
Yeah, no, I would agree. There's something about the follow-up. It's not a sporadic intervention.
And that's why, in my personal opinion, when I was working in UK with a clear pain clinic with all various levels of skills, from conservative therapy to more advanced therapy to the neuromodulation, it's when it's comprehensive, then the outcome is a lot better when it's fractioned level of service.
Yeah.
So that's why I think there is a need for well-structured pain clinics. They could well be. There's a multidisciplinary approach. There's a number of specialists in it, but certainly under the umbrella of a system called the pain clinic, that probably would be the right step forward for our region here.
Professor Hassanin, you're just down the road, or rather up the road from me in Dubai. My question was really what access to neuromodulation, but also pain specialists to do things like, splanchnic or celiac plexus blocks. What's your experience?
Very limited, actually. I don't know. I know there are some people who can do some of that service, but who are they exactly, and how is the skill, and what sort of data they have? Perhaps that need to be more structured, and that's obviously primarily is the role of the big centers, so that when you have the confidence of what number of patients they see, what level of success they have, it give us as the referring physicians the confidence to refer the patients.
Yeah, that's right. Okay, I probably have to get together with you at some point to discuss.
Sure.
Excellent. All right. Well, I think we are 4 minutes away from scheduled end time of 10:15, and unless there are any other questions, I think all that remains is to thank all the presenters, all the faculty for their very comprehensive and thorough reviews on the subject, and thank everybody for giving up a little bit of their Sunday evening. And thank you to Medtronic and the organizers. Many thanks. It was excellent.
Thank you.
Thank you.
all. Very, very enjoyable.
Have a good